Good morning, everyone. So today's class will be on bleaching. Contents will be introduction, discoloration, causes, bleaching, indications and contraindications, mechanism of bleaching, bleaching materials, intracoronal bleaching and its adverse effects, extracoronal bleaching and its adverse effects. Tooth discoloration is defined as any change in the hue, color, or translucency of a tooth due to any cause. Respiratory filling materials, drugs, both topical and systemic, pulp necrosis, or hemorrhage may be responsible. Causes: extrinsic coffee and tea stains, cigarette, diet, tobacco, Nasmyth's membrane seen in epithelium caused due to reduced enamel epithelium. Intrinsic stains, tetracycline stains, first degree, second degree, third degree, and fourth degree, fluorosis stains, trauma to the tooth, systemic conditions such as erythroblastosis fetalis, jaundice, amelogenesis imperfecta, enamel hypoplasia due to deficiency of vitamin A, C, D, iatrogenic respiration, amalgam, intracanal medicaments, and various root canal seizures. Tetracycline staining, more susceptible during second trimester in vitro roughly 8 years after birth. Tetracycline molecules chelate with calcium and get incorporated into the hydroxyapatite crystals. Severity of stain depends on time and duration of drug administration. 4 degrees. First degree, light yellow-brown stains, uniformly distributed, no banding or localized concentration. Response to bleaching in 2 or 3 sessions. Second degree, dark gray stains, extensive than first degree, response to bleaching in 4 to 6 sessions. Third degree, dark gray stains with banding, response to bleaching test bands will be evident. 4th degree does not respond to bleaching. This image you can see the first degree, second degree, third degree, and fourth degree tetracycline stains. Fluorosis. High concentration of fluoride and more than 4 ppm causes moderate to severe discoloration. Prevalence: premolars, second molars, and mandibular and maxillary incisors. Types: mild fluorosis, brown pigmentation on a smooth enamel surface, responsible to bleaching. Moderate opaque fluorosis, appear gray with white flecks on enamel surfaces. Severe defects, pitting and dark pigmentation with surface does not respond to bleaching. Mild fluorosis, severe fluorosis. Traumatic injuries causes rupture of blood vessels in the pulp, causing diffusion of blood into dentinal tubules. Dark pink immediate after trauma and changes to pinkish brown after some days. Causes hemoglobin degrades into hemin, hematin, hematoidin, and hemosiderin. Hydrogen sulfide produced by bacteria combines with hemoglobin and gives dark color to the tooth. Systemic conditions: erythroblastosis fetalis, where Rh factor incompatibility between mother and fetus characterized by the breakdown of erythrocytes. Jaundice, bluish green or brownish stains in dentin caused by bilirubin or biliverdin. Amelogenesis imperfecta is a genetic condition which interferes with the normal enamel matrix formation, and enamel hypoplasia caused by deficiency of vitamins, that is A, C, D, and calcium and phosphorus. Iatrogenic discoloration, trauma during pulp extirpation, hemorrhage, failure to remove of all pulpal remnants. Amalgam restoration causes dark gray, gold dark brown when combined with products of decay. Breakdown of restoration, that is acrylic, silicate, and composite resins, can cause the tooth to look grayer and discolored. Silver containing root canal sealer, that is curved root canal sealer, Grossman sealer, etc., and volatile oils such as yellowish brown stains. Bleaching is a treatment modality involving an oxidative chemical that alters the light-absorbing and/or light-reflecting nature of a material structure, thereby increasing its perception of whiteness. Indication: discoloration of anterior teeth after root canal treatment, tetracycline stains, fluorosis, hemorrhagic discoloration, discoloration due to aging, medication discoloration. Hypoplastic or severely undermined enamel are the contraindications: deep microcracks, sensitive teeth, opaque or white spots, and extensive silicate, acrylic, or composite restorations. Bleaching materials. The active ingredient in two bleaching materials is peroxide compounds. Currently, a variety of bleaching materials are available. The most commonly used peroxide compounds are hydrogen peroxide, sodium perborate, and carbamide peroxide. Hydrogen peroxide in-office bleaching, typically 25 to 38%. At home concentration 3 to 7.5%. H2A2 at high concentration is caustic and burns tissue on contact. Sodium perborate is available in powder form or as various commercial preparation. When fresh, contains about 95% perborate corresponding to 9.9% of the available oxygen. Sodium perborate is stable when dry. In presence of acid, warm air or water, however it decomposes to form sodium metaborate, H2O2 and nascent oxygen. Three types of sodium perborate preparations are available: monohydrate, trihydrate, and tetrahydrate. Most commonly used for perborate preparations are alkaline. Material of choice in most intracorporeal bleaching procedures. Then is the carbamide peroxide or urea hydrogen peroxide. Exists in the form of white crystals or as crystallized powder containing approximately 35% H2O2. It forms H2O2 and urea in aqueous solution, mostly used in home use bleaching materials with concentrations ranging from 10 to 30%. Bleaching preparations containing carbamide peroxide usually also include glycerin or propylene glycol, sodium stannate, phosphoric and citric acid, and flavor additives. In some preparation, carbopol, a water-soluble polyacrylic acid polymer, is added as a thickening agent. Carbopol also prolongs the release of active peroxide and improves shelf life. Bleaching mechanism. The mechanism is an oxidation reduction process called as redox process. In this process, the oxidizing agent has a free radical with unpaired electrons, which it gives them becoming reduced. Reducing agent, that is the substance being bleached, accepts the electrons and becomes oxidized. Reducing agent, tooth, oxidizing agent, bleaching material. After the process, tooth is oxidized, bleaching material is reduced. In addition to the chemical effect, other mechanisms include cleansing of tooth surface, temporary dehydration of enamel during bleaching process, and change of enamel surface. Intracorporeal bleaching or endoluminal treatment. The methods commonly employed are bleach endoluminal are walking bleach and thermocatalytic technique. Walking bleach is preferred. Coined by Nutting and Poe in 1961, involves the following steps: familiarize the patient, radiographically assess the status, evaluate tooth color with a shade guide, isolate the tooth with a rubber dam, remove all the restorative materials from the access cavity, expose the dentin and refine the access, remove all materials to a level just below the labial gingival margin, apply a sufficiently thick layer, at least 2 mm of protective white cement barrier, prepare the walking bleach paste, pack the pulse chamber with the paste, evaluate the patient 2 weeks later. Thermocatalytic. This technique involves placement of oxidizing chemical, generally 30 to 35% H2O2, that is superoxole, into the pulse chamber, followed by heat application either by electric heating devices or specially designed labs. Avoid overheating of teeth and surrounding tissues. Intermittent treatment with cooling breaks preferred. In addition, the surrounding soft tissue should be protected with Vaseline, Ora base, or cocoa butter during treatment to avoid heat damage. Potential damage: external cervical root resorption. Ultraviolet photooxidation. This technique applies ultraviolet to the labial surface of tooth to be bleached. A 30% to 35% H2O2 solution is placed in the pulp chamber on a cotton pellet, followed by a 2-minute exposure to UV light. Adverse effects: external root resorption, chemical burns, inhibition of resin polymerization, and bonding strength. Restoration of intracoronary bleach teeth. Restoration with a light shade, light cured latex composite resin, placing white cement within the composite, waiting for at least 7 days after bleaching prior to restoring the tooth with resin composites are recommended. Extracoronal bleaching. Extracoronal bleaching may be used for whitening vital or non-vital teeth as well as a single tooth or full arch. It has experienced a dramatic advancement in materials as well as techniques after at-home extracoronal bleaching was first introduced. In-office extracoronal bleaching. Bleaching procedures are performed in the clinic by a dental professional. Current commercial in-office bleaching materials are mostly in the form of a gel with 25 to 38% H2O2. In-office extracoronal bleaching may be performed using a bleaching gel alone or a gel with a light. Light source can be a laser, example argon, carbon dioxide, halogen, plasma, or light-emitting diode (LED). The wavelength may range from high ultraviolet spectra, low visible blue light spectra, to invisible infrared spectra such as carbon dioxide laser. The light exposure is intended to enhance the bleaching efficacy by activating the bleaching gel either through a specific catalyst or heat. Lasers. The action is to stimulate the catalyst in the chemical. There is no thermal effect and less dehydration of enamel. Argon laser of 488 nanometers wavelength to 30 seconds to evaluate activity of bleaching gel. As the laser energy is applied, the gel is left in place for 3 to 4 minutes and then removed. The procedure is repeated for 4 to 6 times. Another product uses ion laser technology. Argon laser is used as described before, then carbon dioxide laser is employed with other peroxide solution to provide penetration of bleaching agent into the tooth, provide bleaching below the surface. Argon laser is in the form of blue light and is absorbed by dark color. It is an ideal instrument to be used in tooth whitening when used with 50% hydrogen peroxide. The affinity to dark color ensures that the yellow-brown color can be easily removed. Carbon dioxide, it is unrelated to the color of tooth, energy emitted in the form of heat. It is invisible and penetrates only 0.1 mm into water and distributed when it is absorbed. This energy can enhance the effect of whitening after the initial argon laser process. Diode laser light, a true laser light produced from a solid state source, is ultra fast, taking 3 to 5 seconds to activate bleaching agent. This type of laser produces no heat. OTC products available are directly to consumers, contains acid, citric or phosphoric acid, gel acidic pH applied for 2 minutes, post bleach polishing cream, toothpaste containing titanium dioxide. White strips. This is a thin flexible polyethylene strips which contains 5.3% hydrogen peroxide in gel form. The strips are used for 30 minutes twice daily for 14 days. Adverse effects from extracorneal bleaching. Commonly observed clinical side effect during or after extracorneal bleaching of white teeth with an incidence of up to 50%. The sensitivity usually is mild to moderate and transient, often occurs during the early stages of treatment and usually persists for 2 to 3 days. Enamel damage. The maximum effect of extracorneal bleaching on enamel has been conducted using in vitro systems to examine changes in enamel surface microhardness and morphology. Most SEM studies show little or no morphological changes in bleached enamel surface. Gingival irritation, most commonly observed clinical side effect. The gingival irritation is usually mild to moderate, occurring in 2 to 3 days of using the bleaching gel. Mercury release from amalgam. The amount of mercury release may vary. Avoid extracorneal bleaching for teeth with extensive amalgam restorations. Thank you.